Have you ever thought about just how incredibly bold it is for a whole country to decide, right, we're going to try and eliminate a widespread genetic disease?
It's a huge undertaking.
Yeah, I mean, a public health challenge so big, it needs this massive plan covering everything from, single blood test right up to advanced gene therapy.
Mm-hmm.
So today we're doing a deep dive into exactly that kind of initiative. India's National Program for Prevention and Management of Sickle Cell Disease. Specifically, the National Sickle Cell Anemia Elimination Mission, launched in 2023.
A really significant mission.
Absolutely. And our guide for this is this really comprehensive document, the Operational Guidelines, SCA.PDF, from India's Ministry of Health and Family Welfare.
It's packed with detail.
It really is. So our mission today is to pull out the key insights, maybe some surprising facts, those real aha moments from these guidelines. We want to give you a shortcut to understanding this audacious national effort.
And it's hard to overstate the scale here. Sickle cell disease, SCD, it's one of the most common genetic disorders worldwide. We're looking at estimates of maybe 300,000 to 500,000 births globally each year affected by serious hemoglobin issues.
Wow.
And what's really striking is how much it affects malaria-endemic countries. But now, with global migration, it's a challenge pretty much everywhere.
I see.
And this isn't new. The World Health Assembly flagged this back in 2006, urging countries to develop national programs for these conditions.
And the urgency in India feels, really strong. The document kicks off with this powerful quote from the Prime Minister, Sri Narendra Modi. It really sets the tone.
Mm-hmm.
He says, India's past, history, present, and India's future will never be complete without the tribal community. Tribal populations in India share a disproportionate burden of sickle cell disease. We will usher in a social revolution against this disease and bring in the most advanced science and technology to tackle it.
That really frames the commitment, doesn't it? And it points to something critical, the concentration of the disease. SCD is, very widespread among India's tribal populations. We're talking roughly 1 in 86 births among scheduled tribes being affected.
1 in 86, that's high.
It is, and you see much higher rates in states like Madhya Pradesh, Gujarat, Maharashtra, Odisha. About 17 states in total show high prevalence.
Right.
And this concentration brings specific challenges because often these communities face, poor health indicators generally, and limited access to healthcare.
That makes sense.
But it's not just tribal groups anymore. Because of population movement, migration, you see it increasingly in non-tribal subgroups too.
Right.
India's Ministry of Health, the MOHFW, they actually listed SCD back in 2018 as one of the top 10 health priorities in tribal areas.
Okay, so to really get a handle on this mission, we need to understand the basics first. What exactly is sickle cell disease?
Right. So fundamentally, it's an inherited disorder of the red blood cells. It affects hemoglobin, that's the protein inside red blood cells that carries oxygen around your body. Normally, red blood cells are sort of flexible, disc-shaped, biconcave, and they live for about 120 days doing their job.
Okay.
But in SCD, a tiny mutation in a gene causes the body to make an atypical type of hemoglobin called hemoglobin S, or HbS.
HbS.
And this HbS is the problem. It makes the red blood cells rigid, sticky, and they change shape into a C shape, like a sickle.
Hence the name.
Exactly. And these sickled cells, because they're stiff and sticky, they get stuck in small blood vessels. This blocks blood flow, stopping oxygen from getting to parts of the body.
Okay, that sounds serious.
It is. And what's more, these sickle cells die off really quickly, only living about 10 to 20 days instead of 120.
Wow, that's a huge difference.
Yeah, and the spleen works overtime trying to clear them out, which leads to chronic anemia and often damage to the spleen itself over time. It's actually got a fascinating history. James Herrick first spotted the sickle shape way back in 1910.
Really?
Yeah, and then Linus Pauling, the famous chemist, he defined it as a molecular disease in 1949.
So we have the normal hemoglobin A, HbA, and this faulty sickle hemoglobin, HbS.
Mm-hmm.
How does someone end up with the disease versus just carrying the trait?
It all comes down to genetics, what you inherit from your parents. If you get the HbS gene from one parent and the normal HbA gene from the other, you have sickle cell trait. You're heterozygous, a carrier.
Okay, a carrier. Do they get sick?
Usually not, or maybe only very mildly under extreme conditions. But if you inherit the HbS gene from both parents...
Then you get the full disease.
Exactly. That's sickle cell disease, specifically the HBSS type, which is often the most severe form. There are other types too, like HBs beta thalassemia, where you get HBs from one parent and a beta thalassemia gene from the other. That causes SCD too, with varying severity.
Okay, and this is where the probabilities get really important for the mission, right?
Absolutely crucial. This is why genetic counseling is such a big part of it. Look at these scenarios.
Okay.
If both parents have sickle cell trait, both are carriers, there's a 25% chance, 1 in 4, that their child will have sickle cell disease.
25%.
Right. And a 25% chance the child will be completely normal, inheriting HBA from both. And a 50% chance the child will also be a carrier, like the parents.
So that 25% risk of disease is the key target for prevention.
Precisely. Then, if one parent actually has SCD and the other is a carrier with the trait, there's a 50% chance their child will have the disease, and a 50% chance they'll be a carrier, higher risk.
Right.
If both parents have SCD, then unfortunately it's a 100% chance their children will also have SCD.
Wow, okay.
But on the other hand, if one parent has the trait and the other is normal, then there's a 0% chance of the disease. Their children have a 50% chance of being normal and a 50% chance of being carriers.
Okay, that's good to know.
And finally, if one parent has SCD and the other is normal, all their children, 100%, will be carriers, but typically won't have the disease itself.
So understanding these combinations is vital for families.
Absolutely. It makes genetic counseling indispensable in this whole mission.
And the impact of the disease itself, the complications, they go way beyond just anemia, don't they?
Oh, definitely. People with SCD face a whole range of serious issues. They're much more prone to infections because the spleen, which usually filters bacteria, often gets damaged early on by the sickled cells.
Right, the immune system is weakened.
Exactly. And then there are the recurring, intensely painful episodes, the vaso-occlusive crises, or VOCs.
That's when the cells block the blood vessel.
Yes, it causes severe pain. The guidelines actually highlight VOCs as a major risk factor for death, and the most common reason people with SCD end up in the hospital.
That sounds awful.
It can be debilitating. Other major problems include acute chest syndrome, which is like pneumonia, a high risk of stroke, even in children.
Strokes, too.
Yes, and damage over time to organs like the brain, liver, lungs, kidneys, even things like painful swelling in the hands and feet called dactylitis, especially in babies. It's a lifelong condition affecting the whole body.
Okay, so with that background on just how serious this is, let's look at the government's response. This National Sickle Cell Anemia Elimination Mission. What's the big goal?
The goal is stated very clearly, and it's incredibly ambitious. Eliminate sickle cell disease as a public health problem in India before the year 2047.
2047, wow, that's a long-term vision.
It is, and to get there, they have two main objectives. First, provide affordable, accessible, quality care to everyone who already has SCD.
Okay, manage the existing cases.
Right. And second, reduce the prevalence, the number of cases of both SCD and the sickle cell trait in the population over time.
And the guidelines lay out three main strategies or pillars to do this. The first one is primary prevention. What's the thinking there?
Primary prevention is all about stopping the disease before it even happens. So the focus here is heavily on generating awareness and providing really good premarital and preconceptional counseling.
So people know their status and the risks before having children.
Exactly. Empowering couples with that genetic information so they can make informed choices. Ideally, preventing the conception of a child who would inherit HBs from both parents, the homozygous genotype that causes the disease.
And that needs to be culturally sensitive, I imagine.
Absolutely critical, especially given India's diversity. It requires widespread community buy-in and very careful genetic counseling.
Makes sense.
Yeah.
Okay, pillar 2, secondary prevention and screening. What's the main idea here?
The key word here is screening, universal screening. The aim is to identify people with the sickle cell trait across the population.
So find the carriers.
Find the carriers, yes, so they can be counseled appropriately. And also, crucially, to detect SCD itself as early as possible, especially in newborns and young children.
Why is early detection so important?
Because if you catch SCD early, you can start interventions like penicillin prophylaxis, specific vaccinations that dramatically reduce mortality and serious illness, particularly in young kids. It's about mitigating the impact early on.
Got it. And the third pillar, holistic management and continuum of care.
This pillar recognizes that for people living with SCD right now, they need comprehensive, ongoing support. It's not just about treating crises when they happen.
Right.
It means managing their condition across all levels of healthcare, primary, secondary, tertiary, ensuring they have access to advanced diagnostics, treatments.
Like hydroxyurea.
Like hydroxyurea, yes, but also things like proper pain management, blood transfusions when needed, and potentially even bone marrow transplants in some cases. But it's broader than just medical treatment.
So?
It includes integrating traditional Indian medicine systems, AYUSH, where appropriate, building strong patient support networks, encouraging community adoption programs for long-term help, and providing rehabilitation services. It's about supporting the whole person throughout their life.
That sounds incredibly thorough. What's the actual scope and timeline for rolling this out?
It's a full mission mode approach targeting everyone ages 0 to 40 years.
0 to 40, that's a huge age range.
It is. In the first year, they're prioritizing the 0 to 18 age group. Then in the following years, they'll expand to cover up to age 40.
And the numbers involved?
The goal is to screen, counsel, and provide care pathways for 7 core people. That's 70 million people within 3 years.
70 million. That's staggering.
It really is. The initial focus is on those 17 states we mentioned earlier, where the prevalence is known to be high.
Right. Concentrating efforts first.
Exactly. And a really smart part of the strategy is integrating this mission with existing national health programs.
So not starting from scratch everywhere.
No, they're leveraging platforms like the National Child Health Program, RBSK, and the Safe Motherhood Program, PMSMA. That helps use resources efficiently and reach people through established channels.
Okay, so how does this actually translate to action on the ground? Let's start with that awareness and premarital counseling piece.
This is where the grassroots network is so vital. At the individual sort of household level, you have the ASHAs, the accredited social health activists, and other community volunteers doing home visits.
Going door to door.
Pretty much. Raising awareness, identifying people who might already have symptoms or a family history, creating lists. And they're connecting with existing lists of eligible couples for marriage to offer genetic counseling and refer them for screening.
Bringing it right to their doorstep. What about the wider community?
They're tapping into existing community structures, village health committee meetings, the Anganwadi centers for childcare, women's self-help groups, parent-teacher meetings.
Using those existing networks.
Right. And getting buy-in from tribal heads, local leaders, that's crucial for trust and participation. They're using all sorts of communication methods too, street plays, local announcements, posters, even quizzes. And they're setting up patient support groups.
Peer support.
Exactly. So people affected by SCD and their families can connect, share experiences, support each other. It combats the isolation that can come with a chronic illness.
That sounds powerful.
Yeah.
What about schools? Seems like a key place for awareness.
Absolutely. Community health officers and medical officers are tasked with giving talks in schools and colleges. That includes the EMRS, the special residential schools for tribal students.
Reaching young people directly.
Yes. And they're also training teachers to spot early signs of a crisis, which is actually a really practical, helpful thing. Plus, kids identified with the trait get folic acid supplements through schools or the local health and wellness centers.
Simple but important. And at the health facilities themselves.
Counselors at the primary health centers are getting specific training on genetic counseling for SCD, and the entire primary care team, doctors, nurses, ASHAs, everyone is being trained on all aspects of the disease, so there's a consistent understanding and approach right at the front line.
Okay, and you mentioned something earlier about special cards.
Ah, yes, the sickle cell cards. This is quite an innovative communication tool. Everyone who gets screened receives one.
A card showing their status.
Exactly. It's color-coded blue for males, pink for females, and it clearly states if they're normal, carrier, trait, or diseased SCD.
Simple and clear.
And here's the clever part, especially for premarital counseling. The guidelines describe how a couple can take their cards, place them together, and hold them up to the light.
Okay.
There are holes punched in the cards, and the way the holes line up visually shows the potential risk for their children.
Wow, like a visual probability calculator?
Kind of. So if 2 carriers match their cards, the overlapping holes will illustrate that 25% chance of having a child with SCD, 50% chance of a carrier child, 25% chance of a normal child. It makes those abstract genetic odds much more tangible and understandable.
That's genuinely brilliant. A simple, low-tech way to convey complex information. Okay, let's talk about the screening itself, this universal screening for the 0-40 group. How are they managing that huge task?
They're being strategic by targeting specific groups first to maximize the impact.
Like who?
Newborns are a top priority. Screening them allows for starting preventive treatment right away, which dramatically cuts down infant mortality from SCD.
Okay, newborns. Who else?
Children aged 6 months to 10 years, often screened through school health programs. Adolescents reach through youth health programs. People planning to get married, premarital screening. Pregnant women, especially in the first trimester, so they have options and information for their pregnancy.
Antenatal screening, right.
Yes. And then there's cascade screening.
Cascade. What's that?
That means if someone is identified as a carrier or having the disease, their extended family members, parents, siblings, children are then offered screening too because they have a higher chance of carrying the trait or having the disease. It's an efficient way to find more cases.
That makes a lot of sense. What tests are they using for this mass screening?
For the initial large-scale screening, especially out in the community, they often use the solubility test.
Solubility test.
Yeah, it's a relatively simple, rapid test. It's cost-effective and pretty sensitive, so it's good for identifying potential positives in field settings.
But it needs confirmation.
Yes. For confirmation, they use more definitive tests. There are government-approved point-of-care or POC tests. These are great because they're also rapid, highly sensitive and specific, and can often give a result right there without needing to send a sample off.
So faster results.
Much faster. If POC tests aren't available, or for further clarification, they use lab-based methods like high-performance liquid chromatography, HPLC, or capillary zone electrophoresis. These are very accurate tests that can precisely identify the types and amounts of different hemoglobins.
Okay, HPLC. Got it. Where does this screening happen?
It happens both in health facilities like the Ayushman Bharat Health and Wellness Centers, the ABHWCs, and through outreach camps, often using mobile medical units to reach remote areas. They're also prioritizing areas based on how common SCD is, grading districts by prevalence to focus intensive screening efforts where the need is greatest.
And prenatal testing for pregnant couples at high risk.
Yes, for couples where, say, both parents have the trait, or one has SCD and the other the trait, prenatal diagnosis is offered. This usually involves chorionic villus sampling, or CVS, done typically between 10-13 weeks of pregnancy. It's available at specialized tertiary centers and always requires informed consent.
And newborn screening.
That's also being rolled out, especially in endemic areas. It usually uses a dried blood spot collected from the baby's heel shortly after birth. Again, informed parental consent is absolutely mandatory.
So screening is comprehensive. Once someone is diagnosed, what does that holistic management and continuum of care actually involve for them?
Right, so the diagnosis is just the beginning. The goals of management are really to improve their quality of life, help them live longer, prevent or reduce those painful crises and other complications, and support a healthy lifestyle overall.
Okay, how do they start?
It often starts with prophylactic or preventative management. All patients diagnosed with SCD should take daily folic acid.
Folic acid, why?
Because their red blood cells turn over so quickly, they need more folic acid to make new ones. Also, children up to the age of 5 typically receive daily oral penicillin.
Penicillin, to prevent infections.
Exactly, because their spleen function might be compromised, making them vulnerable to certain bacterial infections, which can be life-threatening. Sometimes penicillin is continued lifelong, especially if they've had their spleen removed. Vaccinations are also really crucial.
Makes sense. What about non-medical prevention?
That's huge, too. Good nutrition is vital, maintaining overall health, and really importantly, patient and caregiver education.
What kind of education?
Practical stuff. Clear do's and don'ts, how to recognize a fever quickly because that could signal a serious infection. The absolute importance of staying well-hydrated. Dehydration can trigger a crisis.
Okay. And for more severe symptoms, you mentioned hydroxyurea.
Yes, hydroxyurea, or HU, is a key medication for people who have frequent crises, say, more than 3 moderate to severe ones a year, or who've had complications like acute chest syndrome.
How does it help?
It helps the body produce more fetal hemoglobin, HbF, which doesn't sickle, and it has other effects that reduce sickling and inflammation. It can significantly reduce the frequency of crises and some complications.
Other side effects?
It needs careful monitoring. Patients starting HU need regular blood tests, usually every 2 weeks initially, to check their blood counts. Medical officers can initiate it, but there are clear guidelines and often referrals to specialists, especially for very young children.
Okay. And when serious complications do happen, like acute chest syndrome or stroke?
There are specific protocols. For acute chest syndrome, it's often urgent hospitalization, oxygen, hydration, antibiotics, and sometimes blood transfusions. For strokes, management might include HU, transfusions, anticoagulants, and definitely referral to a higher center with neurological expertise and advanced imaging.
Are blood transfusions used a lot?
They're used strategically for specific situations like severe anemia, acute chest syndrome, preparing for surgery, or sometimes regularly for stroke prevention. But they're not routine for everyone because of risks like iron overload and antibody formation.
Right. And pregnancy, you said it's high risk?
Extremely high risk for women with SED. Preconception counseling and checkups are vital. They need continuous folic acid, vitamin D. The risks during pregnancy are increased: more infections, preeclampsia, preterm labor, more frequent pain crises. The baby might not grow well. Sadly, maternal and perinatal mortality rates are higher too.
Is treatment different during pregnancy?
Yes, women are usually advised to stop taking hydroxyurea and any iron chelation therapy about 3 months before trying to conceive due to potential risks to the fetus. Management during pregnancy requires very close monitoring by a specialized team.
Okay. And how do they ensure people stay connected to care long term?
Follow-up is built into the system. Patients should have regular checkups, maybe every 3 to 6 months, usually at their local primary health facility or HWC.
What happens at these checkups?
They monitor hemoglobin levels, check for complications, refill medications like folic acid or HU, provide counseling on diet, hydration, stress management, manage any other health issues. Teleconsultations are also being used more, which is great for access.
And who makes sure people stick to their treatment?
The ASHAs and other community health workers, the MPWs, play a key role here. They do home visits, remind people about appointments and medications, and maintain patient registers to track adherence. It's about continuous support within the community. And connecting this to the bigger picture, it really is a comprehensive system. Telemedicine, for instance, is expanding rapidly through the eSan Giovanni platform. Specialists are being trained for SED teleconsultations, and the Ministry of Tribal Affairs is even setting up a dedicated helpline.
So, leveraging technology for reach.
Definitely. And the healthcare system is tiered. District hospitals offer specialist care, while top institutions like AIMS and major medical colleges act as centers of excellence, or COEs.
What do the COEs do?
They handle the really complex stuff: advanced diagnostics like CVS for prenatal testing, bone marrow transplants for eligible patients, acting as hubs for telemedicine networks, and leading research.
You also mentioned ASH integration earlier. Tell me more about that.
Right. There's active exploration of how traditional Indian medicine systems can complement conventional care. There's research on yoga, for example, looking at its potential to reduce stress and maybe control pain crises.
Interesting.
And the Central Council for Research in Ayurvedic Sciences, CASHI, has developed specific Ayurvedic formulations, AUHRP and AUHSC3.
Have they shown promise?
Early findings for AUHRP, based on pilot studies mentioned in the guidelines, sound quite encouraging. Patients reported fewer pain crises, didn't need blood transfusions during the study, didn't develop iron overload, and the formulation seemed safe.
So potentially another tool in the toolkit.
Potentially. Proper randomized controlled trials are underway now to get more definitive evidence, but it's a promising area being actively explored.
And the support system goes beyond medical care too, right?
Absolutely. The ASHAs track patients, help with adherence. Crucially, people diagnosed with SCD are eligible for disability certification under India's Rights of Persons with Disability Act of 2016.
What does that mean for them?
It opens doors to various socioeconomic benefits and protections. And then there's this community adoption program.
Community adoption?
Yes, it's quite unique. Village health committees, called Yanaroja Samitis, help mobilize support. Corporates, organizations, even individuals can adopt patients or families or even whole areas to provide support.
What kind of support?
It could be nutritional support, help with counseling, transport, vocational training, or funding awareness activities. The idea is to boost community awareness, improve nutrition for patients, and reduce the financial burden on families. There's even a web portal for donors and patients to connect, with consent, of course.
That's a fascinating model for community involvement.
It is. And then there's rehabilitative care, making sure patients know about their rights under the Disability Act. Things like free education for children aged 6 to 18, reservations in higher education and government jobs, 4 to 5%, and other entitlements.
It really covers a lot of ground. And technology underpins much of this.
Yes. The National Sickle Cell Anemia Elimination Portal is central. It's a web platform with a dashboard showing real-time progress across the country, user management tools, patient reports.
You mentioned people can download their own certificates.
That's right. Using their unique National Health ID, the ABHA ID, and their registered phone number, citizens can download their own sickle cell status certificate directly from the portal.
That's empowering.
It is. And there's a mobile app, too, for health workers to capture data in the field registration, test results even if they're offline temporarily. It all syncs up to a central repository, linked with the National Digital Health Mission. It provides a really powerful data backbone for monitoring the whole initiative, and making all this happen requires a massive operational framework and coordination. For human resources, they're largely using existing health staff, but adding specific roles like counselors where needed.
And training them.
Huge emphasis on capacity building. The ministry has developed detailed training modules for everyone on the front lines: doctors, CHOs, nurses, ASHAs, covering everything from prevention and diagnosis to the latest management protocols. They're even training teachers and students in those EMRS tribal schools.
Ensuring everyone's on the same page. How is progress tracked?
Through that sickle cell portal dashboard, it allows for real-time monitoring of key indicators. How many people screened, how many diagnosed with trait versus disease, how many registered for care, how many are getting specific treatments like penicillin or hydroxyurea, how many are part of the community adoption program.
So they can see what's working, where the gaps are.
Exactly. It allows for performance assessment, even grading states and districts to encourage progress. And there are dedicated multi-sectoral committees set up at the state, district, and block levels.
Involving different departments?
Yes, chaired by senior officials, but including people from education, social welfare, women and child development, academic institutions, NGOs. It really underscores the collaborative approach needed.
It sounds like a truly national effort.
It absolutely is. The roles and responsibilities are clearly laid out. The health ministry leads, provides guidelines, runs the registry. AIMS and the COEs handle advanced care and research. ICMR drives clinical trials. The Ministry of Tribal Affairs is key for awareness in tribal areas and supporting screening. States plan and fund the rollout. NGOs help with community mobilization and adherence. Red Cross helps with blood. Other ministries chip in for things like school awareness or disability benefits. And of course, the frontline health workers are the ones making it happen day to day. It's a huge collaborative machine.
And looking ahead, what about cutting-edge research? Anything that could dramatically change the game.
Well, there are definitely exciting things on the horizon. One major area is gene therapy, specifically CRISPR-Cas9 technology.
Yeah, the gene editing tech.
Exactly. India's Council for Scientific and Industrial Research, CSR, has institutes like IGIB working on adapting CRISPR as a potential cure for SCD. Imagine a single treatment that corrects the underlying genetic defect.
That would be absolutely revolutionary.
It truly would. It's still in development and trials, of course, but it represents a huge leap in potential treatment. And as we mentioned, the AVUH formulations are also a significant area of research within India. Those interim findings for AUH-RP, fewer pain crises, no transfusion needs during the study, safe, are very promising.
So more evidence is needed, but it's another avenue being explored.
Precisely. The ongoing randomized controlled trials will be key to understanding its role, but it reflects that holistic approach, looking at all potential avenues to improve care.
So putting it all together, what we've really unpacked today from these guidelines is this incredibly detailed, comprehensive blueprint. It touches every aspect, from prevention and screening to lifelong management, support systems, technology research, all coordinated through this multi-stakeholder effort.
It's truly impressive in its scope. The challenge of eliminating SCD as a public health problem is immense, no doubt about it. But these guidelines provide a clear, actionable roadmap. With all these partners involved, it does feel achievable. Knowledge like this is most powerful when it's understood and actually applied. Critical thinking about how these systems work is so important.
Absolutely. And that leads to a final thought for you, our listeners. When you consider the sheer depth and breadth of this national mission in India, what role do you think individual awareness and that kind of grassroots community support really play in making these huge public health goals successful? Not just for sickle cell, but maybe for other major health challenges too. How might understanding this kind of systemic nationwide approach change how you view health initiatives perhaps closer to your own home? Something to think about.